Okay, so I'll start. Ladies and gentlemen, welcome to session 11. It's an absolute pleasure to have you today. Good for you to come. This is going to be super interesting. So I wrote it down, but I'm sure it's true. So today we are going to talk a very fascinating topic, recurrences. So who likes recurrence? I guess no one. I spent the last 3 months of my time here in New York delving into recurrence. And as always, you know, my mindset changed. Once you delve into something, it's becoming more and more interesting. And I think the most interesting thing in life are the most complicated one. Should I what? There it's better. I shouldn't leak the microphone. Okay. So my name is Dr. Louis Gros. I'm a medical oncologist from Switzerland. So this is not Sweden, it's Switzerland. It's the best country in the world. And I'm here today with the best thoracic surgeon in the world, Dr. Nasser Altorki, professor of surgery at Weill Cornell, who published well, this is going to be one of the questions. So he published a landmark clinical trial in the New England Journal of Medicine last year, demonstrating that sublobar resection are equivalent to lobectomy. And on the panel today, we have a wonderful panel. We have Dr. Beasly, professor of pathology at Mount Sinai and head of pulmonary pathology. We also have a world-famous medical oncologist, as well as she is also the CEO of the I-ELCAP, who recently led a fabulous meeting in San Diego, where I was, but also where my boss, Dr. Henschke, who is also on the panel, received the Prevention Early Detection Award. I think we can applaud to that. We also have Professor Flores, a lung surgery specialist, and also professor at Mount Sinai, and silver medal today. Okay, Dr. Harkin, professor of medicine and director of bronchoscopy here at Mount Sinai, and Dr. Samstein, a radiation oncologist in the Department of Radiation Oncology at Mount Sinai, who also holds the title for fastest email responder from this panel. It's a very important quality. So I prepared just 2 slides to put some context, and then we can start our discussion. So medicine is hard, as we all know. So thanks to lung cancer screening, we can detect lung cancer early and usually at a curable stage. However, and this is the sad part, patients with stage 1 lung cancer, so cancer less than 3 centimeters, can still experience recurrence or develop what we call a second lung cancer. So when we talk recurrence, there are some straightforward cases. So one patient, this is the first 2 lines, patient undergoes a lobectomy for 25 millimeters lung adenocarcinoma, and then 1 year later develops liver metastasis. So this is a sad story, but fortunately such cases are pretty rare with stage 1 lung cancer. Most common cases look like this. So a patient with a 25 millimeters lung adenocarcinoma resected, and 1 year later in his follow-up CT, he presents with a new lung nodule that continues gradually to increase in size and is subsequently diagnosed as cancer. And the key question here that we're going to talk about today, is this a recurrence or is this a new primary lung cancer? And Dr. Beasly is going to give us a point of view of pathology on this topic. You want to come here?
Thanks. Can everybody hear me? Great. Okay, so I really did this more for the staging session coming up next, but I think there's a lot of overlap with this session. So in regard to determining whether a pulmonary adenocarcinoma is the same tumor or a different tumor, sort of has the same approach regardless of whether they're synchronous or metachronous. So what we're doing from a pathology standpoint is obviously trying to figure out if they're the same or different. So first of all, when we get a specimen that has two tumors at the same time, which isn't really so relevant to this session, they do need to be grossly and radiographically distinct. So what happens from a pathology standpoint, often you'll have a little bit of tumor on the same slide off to the side. That doesn't count. They have to be totally distinct tumor. Multiple ground glass lesions, according to the current staging guidelines, that typically correlate with what we see pathologically as adenocarcinoma in situ, minimally invasive adenocarcinoma, or lipidic predominant adenocarcinomas. Those are staged as separate primary tumors, regardless of what the molecular shows. And I'll talk about molecular in a minute. So our main issue that is challenging are multiple solid lesions, or when you have a mixed pattern. Obviously, it's easy if you've got two entirely different histologic subtypes. So you've got one adeno, one squamous. That's usually fairly straightforward in regard to those being two separate tumors. But multiple adenocarcinomas that are solid or mostly solid are particularly challenging. And the evolution of how we sort these out has evolved over time. For years, we were using the Martini and Melamed criteria. We're probably all familiar with those. In the interest of time, I won't read through them. This actually still isn't that bad, but it's also not good. Currently, what's recommended is comprehensive histologic evaluation. So as we said, AIS, MIA, or LPA is always its own primary if it corresponds to ground glass lesions radiographically. Otherwise, we are looking at the predominant histologic growth pattern. Is it acinar? Is it papillary? Is it micropapillary? What's the secondary pattern? What's the cytology looks like? So generally, if a tumor looks alike, it's going to be an intrapulmonary metastasis or a recurrence. If they look different, they're going to be different. Now, that works pretty well, but there are exceptions to that. This is just briefly the current AJCC guidelines for this, so you can see how we evaluate different multiple nodule situations in the lung in regard to the pathologic staging. So you have second primary lung cancers. Again, you're looking at the pathologic features, the radiographic features, and trying to make some sort of educated evaluation about similarity and difference and whether they're the same or different. Okay, now as I said, molecular. In an ideal world, you want to get molecular on all the tumors. So if you got two tumors, you want to get molecular on both of them. Different molecular helps you the most. So obviously, if you have two different driver mutations, those are different tumors. If you have the same molecular, that's a little more challenging, and it kind of depends on how large your panel is. So if you have single gene testing and you end up with a KRAS G12C mutation, which is fairly common, and you've only got a single gene analysis, you kind of don't know if you've got two tumors that just happen to have the same mutation, or if they're metastatic one from the other. So with a larger panel, that's ideally what you want to get. So if you see downstream mutations that are going to be statistically unlikely to occur simultaneously, that's helpful as well. So a bigger panel is helpful. Different mutations are helpful. Single gene panels, you have to be a little more careful about. So this was a nice paper out of Memorial, but there's a few different papers that have looked at this, looking at intrapulmonary metastases versus separate primary lung cancers. And generally, you can see that yes, If the tumor looks alike, most of the time it has the same molecular and it's the same tumor. However, there are instances where tumors look alike and they have different moleculars, so those are determined to be separate primaries based on the molecular analysis. And then conversely, you can have tumors that look different, which we, as just looking at the slide, would think were separate lung primaries, but they end up having the same molecular. So what is thought to have happened there is that you have a high-grade subclone that's metastasized, that's got the same molecular as the original tumor that looks different histologically. So that's the most common scenario that's happened there. So just to briefly sum up our approach, we want to look at what the tumor looks like. Generally, if they look the same, it's an intrapulmonary metastasis or a recurrence relevant to this session. If they look different, they're usually different. That being said, in an ideal world, you do want to do molecular testing and a reasonably large panel on all of these tumors to try to increase the probability of your being right or wrong. And then I think in the instance of recurrence, the clinical really comes into play, and we'll hear more about that. So thanks.
Thank you, Dr. Beasly. Here's just one slide where when we are talking about molecular, so actually all cancer have some sort of mutation, but for nearly half of them, we have what we call targetable alteration. There are 9 of them. Those are genetic driver for whom we have some sort of targeted drugs. I'm a medical oncologist, so I love drugs. But let's go to the first question for the panel. And it's simple. How good are those current criteria for distinguishing second primary lung cancer from recurrence? Dr. Flores, do you want to start?
So the question I would ask is, does it matter? You know, if you resected a lesion as a surgeon, we see it frequently where you've already done a lobectomy or a limited resection on one side, and on the other side, you see a lesion, one lesion, no evidence of metastases anywhere else. Let's say if molecularly you could determine that that was a recurrence, would you not operate on that? It's a solitary method. So from a surgical standpoint, it doesn't always matter. I think from a medical standpoint, from giving them chemo or targeted therapy or immunotherapy, it probably matters more. But from a surgical standpoint, when you just have that one lesion, is it a recurrence or is it a second primary? Either way, you're going to take it out.
Does time matter?
And that's a good question. Does time matter? Is it, let's say if it's a second primary, was it a little something there before that you didn't see that over time has increased in size?
So it wasn't there before and the patient comes to see you 9 months after surgery and there's something there.
That's a good question. If it's isolated and it's easily removable, I'd remove it. And then you can compare the two, see what it looks like. If you see a patient like that with something that came back a year later and you biopsied it and there was a question that it was different, would you rather give that patient immunotherapy, targeted therapy, chemotherapy than operate?
You're asking me? I'm supposed to moderate.
You're supposed to answer the question.
Okay, in general.
No,
general.
but that's important.
Yeah.
For me personally, time matters only in the sense that it influences the choice of treatment. I am less likely to reoperate on a patient who develops a nodule 6 or 9 months later, as opposed to, for example, asking our radiation therapist to intervene with local ablative therapy. I think just weighing the risk and the benefit of a second operation, because most likely to me that this patient is on a different trajectory in terms of the natural history of their disease than somebody who shows up with a nodule 3 years later or 2 years later. But that's opinion. That's not.
But I mean, that's the premise of lung cancer screening. You're screening, it's not just a one-time screen. You screen every year to anticipate to intervene in those lesions that are developing within that 1 year. So even if it's 6 months later, how do you know that didn't just develop into a curable cancer?
I'm not, that's not the question I'm trying to answer. The question is, how does that affect the treatment plan? That's the only way it affects my treatment. We both agree that it should be ablated surgically or non-surgically.
Dr. Kelly, do you want to comment on that?
I do think it's important, particularly this was within a year, so you are worried that it's going to be a recurrence, but it could be a second primary. And I do think we need to get the evidence because it does make a difference. It doesn't make a difference in terms of local therapy, but there would be a discussion at tumor board about should that patient after local therapy get some adjuvant systemic therapy. And that could be the case, or it could not be the case. It just would depend. If it was totally all EGFR positive, then perhaps you would give, it's recurrent, you could give osimertinib. So we would be having those discussions. I do say that for the most part, even when we give a local therapy, we typically don't give additional therapy because we don't really know how long we're supposed to give it. I think the only consideration right now would be for alectinib and osimertinib right at this point. Could we give immunotherapy? We could do that too. But again, we have to have that discussion. We have tended not to do those things, but perhaps now with the benefits that we're seeing even now with immune therapies, perhaps now we would give it. But when you have a good local therapy, you may not want to give anything else. But the 1 year time frame is worrisome.
Thank you. So we're gonna go to the second question that you kind of already answered, but is it really important to distinguish between recurrence and second primary? I just want to mention to our public that second primary lung cancer are now ranked number 5 in cancer deaths. So we are number 1 and number 5. So it's going to be with prolonged survival. This is going to be becoming a real topic. And we're just going to start with a case so we can discuss it a little further. So this is the first case. I have 3 of them. So 68 years old, female, white, past medical history, COPD. She used to smoke 40, so she has a smoking history of 48 back years, but she stopped 3 years ago. And in February 2019, she underwent a left upper lobe wedge resection. And the pathology report says, okay, it's an adenocarcinoma, 7 millimeters, acinar subtype, grade 2, no invasion. And she also underwent molecular testing, which is, as of now, not mandatory for those tumors. And the NGS says KRAS G12V, which is the most common mutation in smoke. So follow-up, 1 year later, in the right lower lobe, there is this small nodule who appears, is non-calcified, is solid, but it's 3 millimeters. So we said, okay, let's follow up this nodule. It continues to grow to a 9 millimeter nodule, and then we convinced Dr. Yankelevich to do a biopsy. The biopsy says malignant. So she underwent a second surgery, this time in the other side, so right lower lobe wedge, who says adenocarcinoma, 10 millimeters, solid subtype, grade 3. Once again, no invasion, and the same molecular signature, so KRAS G12V. So what are we supposed to do now with this patient? Dr. Kelly, you want to comment on that?
Again, I would watch this patient. Even though they do have the same molecular subtype, they're completely different, different lobes. There wouldn't be any systemic treatment for this patient. I would watch this patient.
Dr. Samstein, would you propose some radiotherapy on this node? No.
I mean, I think the patient has been cured of this cancer, whether it was in recurrence or primary. I think in this setting is mostly an academic question of interest, but I think has no practical impact on how we should be managing the patient in this case.
But in practice, we saw those cases, and we have even patient who underwent a third wedge resection, and then you ask, okay, should we continue to do that or not?
I think as of now, we don't have an indicated therapy that can potentially prevent a third primary or even a third recurrence. I mean, perhaps you'd say this is a little different if it was a targetable mutation. For KRAS, we don't. And so we don't have a good chemoprevention agent to prevent that third primary. We know this patient's at risk, but we're going to watch them and address it when it develops.
Thank you. So now we after this first case, we have a presentation from Dr. Altorki from a phase 3 trial is from Cornell.
So I just thought that, yes.
So we are discussing second primary, there is a gap in our knowledge, and I never hear anything about tumor heterogeneity. In tumor heterogeneity, we had a fellow in my lab who looked into autopsies in EGFR positive patients. And some of the tumors were clearly EGFR positive, and some of the metastases were clearly EGFR totally negative. We know that you can have adenocarcinoma in one end, and you can have squamous cell carcinoma in another end. That is a well-known pathologic phenomena. The second primary could be that you have a second component in the same tumor, which is growing much slower or is selected based on therapy or whatever it is. So I'm very confused from a biological point of view, distinguish between a second primary and a part of the first primary. And I think that needs to be had in mind when we are discussing therapeutic implications of it. I don't know if people, this is a little bit provocative statement, but tumor heterogeneity is well known, and lung cancer is one of the role models for tumor heterogeneity, whether you're talking morphology or biology, but we don't have the knowledge yet.
Yeah, I think that's actually a good summary of the state of the art, as it were. Everybody is confused about how to define this. It used to be that, you got one squamous and one adeno. That's clear. There is no doubt there. The problem, of course, is that when that was developed by Martini and Melamed, that particular criteria, squamous then constituted 50% of lung cancers in this country and 70% of the lung cancers in Eastern Europe and elsewhere. And now, in at least in our trials, about 60, 70% of the patients have adenocarcinoma. And yes, they can have different lipidic predominant or acinar predominant, but the other one is papillary predominant. But that, somehow I find that not very reassuring, Dr. Beasly. I thought that for the next few minutes, I just want to share with you what the findings are from the randomized trial, which are, to me, are very troubling. So these are the usual criteria: disease-free interval of at least 2 years. I mean, why 2 years? Why not 3? Why not 5? So that's all arbitrary decisions. Separate lobes without intervening common lymphatic involvement. So what happens in the era of sublobar resection? What if you take a segment and then you have in the same lobe in a different segment? And then, of course, the different mutational profile, and you spoke to that, the different mutational profile. I think this is the best we have. I don't think that it is foolproof. So this is the trial. And we randomized 697 patients to have either a lobectomy or a sublobar resection. And what we were interested in is the incidence of second primary. And with a median follow-up of 7 years, you can see how the curves are constantly going up. That's a second primary. Now, I would say that second primaries were determined by the local PI. We gave no guidance. Whatever the local PI thought was clinically a second primary was called a second primary in the case report form. And if you look at it, the usual incidence is 1 to 2% per year from all the retrospective data, and 2% was thought to be at the higher end. But it turns out it is actually higher than that. So if you look at the entire trial, it's about 16%, 17% in the sublobar resection group. And well, you guys can see, in the lobectomy arm, it was almost 15%. In the sublobar resection arm, it was 17%. And the rate per year is almost double what's reported in the literature. So one of the knocks against this analysis is that we started from time zero. And many of the PIs may have had the same issue of, of seeing a lesion within 6 months, 9 months, or so forth, and called it a second primary. So we re-examined it using a landmark time of 2 years. So 2 years and you're disease-free. What was the incidence after that? And that's the cumulative incidence. And it again is a curve that keeps going up. And overall, it was 3% per year, 2.8% for the lobar resection arm, and 3.2% for the sublobar resection arm, which just says, these are patients who have field carcinogenesis. And the more lung you have left behind, the more likely that they will develop a second primary. That is no argument to do a bilateral pneumonectomy, but it's just something that one should keep in mind. So these patients really are never, with respect to, I'm in a screening meeting here, they're never really cured. The data from the screening is that we cure about 80 or 90% of the patients, and that is correct. But that's in a screened population. These are patients that are not been in a screened population. They are incidentally found in routine clinical practice. So these patients should never, ever fall off the grid and be sent on their merry way. That is, of course, in addition to the fact that 30% of them do have recurrences. So we looked at what variables are associated, clinical and other variables that may be associated with the risk of a second primary lung cancer. Nothing really popped out that was statistically significant in either a univariable or multivariable analysis. And then we asked the question, well, is there a way that we can find that it matters, that whether it's a recurrence or not? And I will, the curves here are self-explanatory. The overall survival on the top is for those who never recurred and never had a second primary. The bottom one are the ones who had what it was deemed to be a recurrence, and the middle is the second primary. So the significance is not important, but it's sort of an intermediate thing. So yes, it does matter if you call something a second primary or not. Unfortunately, we're not very good at calling that accurately most of the time. So these are the data that we have, and the alarming thing is that we should always be looking for these patients to come back for a screening.
Thank you very much for this presentation. I think, yeah, maybe one thing we know is that patients should stop smoking, but that's about it. I'm gonna.
But these are recurrences that could be distant recurrences or local recurrences here, right?
Yeah.
It's everybody. It's
Yeah.
everybody that's
Yes,
recurring.
that is correct.
So I think what we really want to know is what we've just been talking about are
Solitary.
those patients who have the solitary
Yeah.
nodule, because it could be that it isn't
Yeah.
quite
Exactly.
as bad as
Yeah.
that curve looked.
I have two cases here to enlighten the discussion. I think very interesting. So case 2, it's a 77-year-old male, black,
past medical history, well, he had a myocardial infarct, so probably never had a coronary artery calcium score. But so he used to, no, he's still smoking, 33 pack years. And in January 2020, he underwent a wedge resection. Surgical pathology said, oh, it's a squamous cell carcinoma, 14 millimeters. Once again, no invasion, everything seems okay, we are happy. 4 years later, and this is where time is an interesting component, then there is this growing nodule for 6 months, and well, biopsy says, once again, squamous cell carcinoma. It's in the same lobe, and now what should we do, Dr. Flores?
I mean, even though they're both squamous cells, it's in a completely different part of the lung. It looks, it doesn't, I would probably do another sublobar resection on this. I wouldn't give any systemic therapy, anything like that. Could you do radiation? You could, but I would just take this out.
I think this depends also, of course, on lung function of those patients.
Would anybody jump to a lobectomy here?
This is a current smoker who had some emphysema, so I think your point is well taken about you need to figure out what his lung function is because he's a current smoker and he may get, again, other lung cancers again. So with his current smoking status, he obviously didn't quit smoking after the first lung cancer. So he's likely to get the third or the fourth or even metastasize.
And there is the issue of the age and cardiac comorbidity.
Correct.
And the fact that these are both on the same side. So it's surgery, you know, is definitely something that comes to mind immediately, but it's not necessarily a slam dunk in a 65 or 70-year-old who's otherwise in good shape. I would agree totally. But Dr. Samstein, what are your thoughts on that?
I mean, I think there's consensus here, obviously, that this is a local problem. 4 years, the time interval, I think, is reassuring in that this is likely a separate process and there's a local problem. And I think consensus is clearly a local treatment. I think whether you know, SBRT certainly would be an option and something that could be treated very safely and probably effectively in this location versus surgery is going to be ultimately a personalized decision based on the patient, the individual patient.
I think one of the questions with this late new primary is how long should we follow up our patient? What do you think, Dr. Henschke? It's for life?
Absolutely, because, you know, they've been smoking, that's a field effect. The entire lung is involved, and why should, you know, and the CT scans are getting better and better. So when we see a new nodule, and in fact, lots of the ones that have surgery for the first primary have other nodules. So I think we need to really rethink that from a statistical point of view, that if the person survives, he's likely to have another, he or she are likely to have another nodule and another cancer. And we should really give the benefit of the doubt that it's a separate primary if there are no lymph nodes involved. And we should follow them for the rest of their life.
I 100% agree with that. I think that's, you know, once they pass the 3-year mark, I tell them that the risk now, your highest risk is not recurrence of the cancer, but a second primary. But I would like to ask you, Dr. Kelly, you know, we showed that these recurrences occur in stage 1. Where are we with trial that intervene at this stage?
Well, this is a gap, I would say. This is a gap. We have really only one trial in this space, and that's Adora 2, that is looking at, I believe it's 2 centimeters to 3 centimeters, looking at osimertinib versus placebo, but that is it. That's the only trial that I'm aware of that is actually looking at the earlier stage. The bar is so high, of course, here, that is where there's hesitancy when you start looking at the data. But I do think, and one of the great things about ADORA 2 is they did select that high-risk patient population. And you, on your slides, made a very good point. There's no lymphovascular invasion, all of, some of those high-risk features. He did not have that. I don't think any of these patients did. But in ADORA 2, you have to have at least one high-risk feature that they've defined: lymphovascular invasion, other things, high PET, activity. I can't remember. I think there's another one as well. But nonetheless, that I think is the patient population that we really want to target with systemic therapies, at least right now. So, but unfortunately, I only know of this one study.
I want to know from Professor Harkin, where are we with ablative therapies now? Bronchoscopic therapies. I mean, this is becoming a pretty hot topic. How much tissue sparing how much tissue sparing might it lead to, et cetera?
Yeah, I mean, this is, so in interventional pulmonology, this is a very hot topic because a lot of the treatments are hot. But we're not ready for prime time yet. That's kind of the quick answer.
You're so humble.
No, it's all seriousness. I mean, when we started talking about robotic bronchoscopy and navigational bronchoscopy, it's incredibly expensive equipment. It's about $600,000 for the unit that we have, 2 of now. And to me, especially working with a colleague like Dr. Yankelevitz, for him to biopsy that nodule is no problem. I know. So do I have to spend $600,000 in order to allow me to biopsy that? And I was a little concerned about that. I mean, I like new toys and I like expensive toys and that sort of thing. But the real question is, what's the real value added of getting such high-tech stuff to be able to better biopsy that when I have another biopsy technique that is probably at least as good in terms of yield, maybe a little bit higher complication rate. And to me, the attraction was therapeutics. And I think that that's really where the field is heading. We can reach these nodules bronchoscopically, we can do it either with the conventional techniques that we're using now. Generally, we'll use, for those of you who aren't familiar with this, it's navigational bronchoscopy. The system that we use is purely navigational and virtually guided. And we navigate out to this target, then we pass a radial ultrasound probe through the scope, and we can hopefully see the target and adjust your angle precisely to get the optimal angle, pass a needle through it. Ideally, we have a cytology tech in the room telling us that we have it. So that's really attractive technology. It's a very low complication rate. Pneumothorax rate is about 2% or less, actually lower than most of our bronchoscopic biopsies. Bleeding rate is extremely low. So very high yield and safe. And that's our initial experience thus far. We've been using this for about 2.5 years, and it's phenomenal technology. We can hit this sort of target pretty reliably now, whereas 10 years ago, I would not have had a great chance at that nodule. So I think that now that I'm using it, I'm all in. I think that this is a great diagnostic tool, but I still think that ultimately the value is going to be in therapeutics. There have been a couple of studies. One was looking at microwave ablation, had an early death in that trial, and that kind of shut things down for a while. And that was very early in our experience, about 2 years ago. There are a lot of different modalities: cryo, microwave ablation, RFA. There are other technologies now that are also not related to heat-based therapies. They're all very much investigational. There are a couple of case reports. I think one of these is going to pan out, but what we don't have yet is a good, large trial of these sort of technologies. And I think that that's overdue, if anything. But I think there's a lot of nervousness because there were a couple of, mishaps early on that were, a couple of fatalities. I think there was another fatality as well. So there's a lot of caution around these, so tempering the excitement. But I think we're going to get there. I think that this is going to be very feasible. And for this sort of patient, I think this is great. I mean, this guy, he's been smoking for 33 years. He's still smoking. He's 4 years older. His lungs are 4 years older. He's got, another, so many pack years under his belt. And then he's going to get another primary if he's still alive 4 years from now, right? So using this sort of really focal therapy that has good efficacy, low complication rate, and the field is predictable that we're not cooking the wrong half of the lung. You have to be really sure that you're in these lesions. There's a lot of stuff logistics that need to be worked out. So that's a very long-winded answer. The short answer is not ready yet.
Thank you. This sounds very exciting.
And another therapeutic avenue which is coming and explored these days is immunoprevention, whether it is early prevention based on screen-detected nodules, whether it is bronchial dysplasia, or whether it is prevention of recurrence. But over the next 5 years, you will see several of those studies. There are a few ongoing these days in the early phase. It is MD Anderson has a canakinumab study, IL-1 beta inhibitor. The Colorado group has demonstrated, and I heard with very promising preliminary effect, some cycles of nivolumab for bronchial dysplasia. So I think in the future you will see that might be more relevant in the post-surgical space to prevent recurrence. And we are working on that concept here too. We haven't materialized it yet, but we have discussions around it.
There is one trial, the IMPRINT trial, that has about 80 patients in what's determined to be high-risk indeterminate nodules, and you have to meet certain criteria, and you get the pembrolizumab for 4 doses, or you don't get anything, and then at the end of 6 months, the endpoint is, did that pulmonary nodule disappear or not? So it's the IMPRINT trial that is, again, a very small study.
Another trial in the post-surgical stage is the LungBax trial in the UK that's looking at more of a vaccine-based approach using the molecular information that you can learn from the surgical specimen and potentially vaccinating against it. So I think those are all exciting things for the future based on, the alarming data that Dr. Altorki showed us.
So we need to continue the hard work. I have a last case just as illustrations that recurrence are also, not all recurrence are the same. This is a 61-year-old female Asian who is a light smoker. She smoked only 5 pack years. She stopped for 20 years. She underwent a wedge resection, adenocarcinoma, grade 2, no invasion. She had some stats, and she was EGFR mutated. And 6 months after surgery, you see a little thickening of the suture line, and 2 years later, there is this nodule attached to the suture line. And thanks to Dr. Altorki, we're gonna have more and more wedge resection. And I think this sort of recurrence should be treated separately than other recurrences. But in the I-ELCAP database, we have a few of those. And right now, we don't really know how to treat them. We do personalized treatment, surgery, or radiotherapy, depending on the patient. And I think we need to look into how to better treat those patients.
For me, that is biologically different from having a second nodule that we are going to discuss. But this is, I hope I did not do this operation. That's a failure of local treatment. So it's, one can, you reapply the local therapy with a wider margin or with radiation, what have you. So I think that's I think that is the first and perhaps last step in managing these patients.
Yeah, I think
But-
the key, sorry.
Just to challenge you, why, if you had a good margin and you had a new nodule that came up, why wouldn't you consider it also as a second primary? give the patient the benefit and not immediately classify it as a local recurrence.
This one here?
Yeah. Well, this one here.
I mean, I think,
It was
for
right,
me,
right
if
now.
it's,
I don't have enough information,
Yeah.
but at least in general.
yeah, I think if it's on the staple line, I would like you to call it a second primary because that takes the heat off of me. But it's hard, just hard to escape blame here.
Go back to that original CAT scan for a second.
I'm
Can you go
touching-
back to the scan before?
I'm touching all the buttons. Maybe that's the problem.
One at a time, right? But if you look at the original film, it's hard to get a positive margin on that thing. That is such an easily wedgeable lesion, right? Where I think Claudia's point is a good one. How do you know that's not a second primary? I mean, a medical student can do that type of operation. That is not, maybe that's what happened.
So I think we run out of time. I just want to say as a conclusion that second primary and recurrence are probably not the same. And I think we should work on learning to better distinguish them. That will make us better doctors, will help us better treat our patient and make us better human being. That's what we are aiming for. Thank you, the panel. Thank you for the discussion.